This next session is on CACNA1A-related hemiplegic migraine, what it is and what is being done. I can tell you when we started organizing the conference, the number one topic our families wanted to hear about was a hemiplegic migraine. There's an incredibly significant clinical unmet need in this area. Our patients, including some of them today, are in the hospital with hemiplegic migraine episodes, and there are not good treatment options, and there's a lot of misunderstanding about how to treat them or even to issue rescue medications. So we are incredibly grateful for the next three panelists who are all joining remotely today. Dr. Ingo Helbig has been an incredible partner in this work and has been instrumental in trying to help us advance the development of treatment guidelines for CACNA1A-related hemiplegic migraines. Dr. Irene DeBoer is at Leiden University Medical Center and has been a great partner and is committed, I think, to helping us continue to push this area forward for our patients, both from a medical, clinical perspective and a research perspective. And finally, Dr. Zamil Cotter, who just joined our scientific advisory board and is doing a lot in the area of migraine research, not only for CACNA1A-related hemiplegic migraines, but migraines generally. And so we're really excited and looking forward to hearing from you all about what we can do and what's being done. I think we're going to start with Dr. Irene DeBoer's presentation.
I was invited by the CACNA1A Foundation to give a talk about hemiplegic migraine at the CACNA1A conference. Before I start, I cannot mention how thankful I am for the Foundation for organizing this amazing conference, and that I'm very honored that I can speak with you today. I gave this presentation virtually, but there were some technical problems, so they asked me to do a recording as well. And I hope that this helps the patients that it gets to. So before I start, I want to shortly introduce myself. I am Irene DeBoer. I am a physician and a researcher working on hemiplegic migraine at the Leiden University Medical Center, which is located in the Netherlands. Shortly, here are my disclosures. They're not of interest to this talk, so I will go over them very quickly, and then I'll get to what's important. Hemiplegic migraine. And what is hemiplegic migraine? Well, shortly put, it is a subtype of migraine with aura, which is much more common. And it often is associated with a migraine headache, so the typical features of a migraine headache. And then there are also aura symptoms. Aura symptoms can be very diverse. For instance, problem with vision, which can be zigzag lines in different colors, but also lack of vision. Patient can have language difficulties, so they can't speak, for instance. And they can also have sensory difficulties, so numbness of pins and needles feeling in their limbs. But what makes it hemiplegic migraine is that in combination with these symptoms, patients also suffer from weakness. So this is specific for hemiplegic migraine, an aura with weakness. What's special about hemiplegic migraine is that it can be caused in an autosomal dominant manner. So one mutation can cause the disease. And there are 3 genes known which can cause this disorder. And the reason I'm talking with you today is because one of these genes is CACNA1A. So it's important to discuss hemiplegic migraine when we are talking about CACNA1A. Before I go into depth about hemiplegic migraine, I want to give a short overview of our laboratory and our clinic. So our clinic is run by Professor Gisela ter Wind. And what we do here, we do a lot of clinical care. So we see patients with mutations, also without mutations, with hemiplegic migraine. And we try to give them the best care possible. We also do a lot of research in patients. So for instance, we do imaging, but also biomarker studies to try to understand hemiplegic migraine. And finally, what we do in the clinic is consultations. So if there are physicians that are seeing hemiplegic migraine patients and they have doubts about the treatments, they can contact us. What we also do is that when there's a mutation found and it's unclear whether this is actually causing the disease, so we think with the physicians about this. Is it a CACNA1A mutation that is leading to this disorder, or is it something else? So for all over the world, we are contacted by physicians who would like us to assist, which we of course do happily. Then I want to shortly introduce our laboratory, or actually laboratories. So these are run by Professor van der Maagdenberg. And we have several laboratories in which we do studies related to hemiplegic migraine. So we have a kind of a normal laboratory, as much as laboratories can be normal. And here we do, for instance, genetic testing to see which families have the mutation. What we also do is animal work. And for this, we have a special animal laboratory. And this lab is focused specific on animal studies. Of course, we would prefer not to have to use this, but sometimes there are no other ways to do an experiment than use animals. So then we sacrifice them for the science. These animals are very special because they have a mutation in their genes, which is the same mutation as patients with hemiplegic migraine can have. So we can learn a lot about their physiology because of this. And finally, we have one more laboratory, which is a cell culture lab. And in this lab, we can do cell function studies. So we can actually look at cellular level, so the very small cells in your body, and see how do they work. And also, if they have a mutation, how do they work then? And so we can do very different experiments in very different models, but I will tell you more about this later. So what will we be talking about today? Today, I would like to give you a very small overview about research, which is done in hemiplegic migraine. I could talk with you about this all day, but of course, we do not have as much time. So I just want to give you an idea, what can these models be used for and how are they being used? And then I would like to move on to the clinic. So we'll start with the research part. Why are we doing research? Well, one of the important things is that we want to unravel how hemiplegic migraine works, because if we understand this better, we can move towards treatment. And to do this, we do work in patients and the models that are already described a bit. Importantly, what we also do is we translate these findings. So what we see in the patients, we quickly try to translate to models to study into more detail. And if we find something in our models, we want to get back to the patient so we can use it as much as possible to find the treatment as fast as possible. So this translational part of our research is really important. To start with the animal models. Here at the bottom of the screen, what you can see is kind of a drawing of a mouse. So this mouse has an electrode and another electrode. And using one electrode, you can give the brain a stimulus. This is important because we can use this to measure something that's called cortical spreading depolarization. We already had another talk which also discussed this, but cortical spreading depolarization is basically an electrical wave that moves across the brain. And this is important because we think that this electrical wave is causing the migraine aura, so also the weakness that we have in hemiplegic migraine. And what we found in animal models is the following. What we see here is the threshold needed to cause the cortical spreading depolarization. So this threshold, if it's high, that means that you're not likely to get a migraine attack. If it's low, it is likely that you'll get an attack. And what we see here is the wild type, which is the healthy mice, in which it is high, but the mutation in CACNA1A makes it lower. Interesting enough, these are two different mutations in CACNA1A and both cause hemiplegic migraine. However, there is a difference. So it appears that this mutation, the threshold is higher. This is not surprising because actually when you look at the clinic of this patient, this is exactly what you would expect, because patients with the S218L mutation are more severely affected than the other mutation. So this is a very interesting finding that you can actually see the severity in the how high the threshold is. So this is really important. So just to give you a better view of what we're talking about, I would like to visualize it a bit more. So when we talk about this threshold, when we relate it to patients, if someone is healthy and does not have migraine, we expect them to be very far from this threshold and to never reach it. While migraine patients are much closer, and this can be due to those mutations in the hemiplegic migraine genes. And then if there's a small trigger, for instance, bumping your head, this can actually lead to an attack happening. So this is just to visualize what we think is happening. Next, I would like to move on to this very difficult graph. And please don't try to understand it completely. This is not necessary. But what I want you to show you is that there are actually several genes that can cause hemiplegic migraine, and they all lead to the same common mechanism. So what we see here, we see a nerve cell. And this nerve cell is talking with another nerve cell. And this talking is done by messenger molecules. These messenger molecules are released from one nerve cell and go to the other to get the message across. And the different mutations in hemiplegic migraine genes among them CACNA1A, leads to the fact that there are more messenger molecules that can talk with the cells. So because there's increased amount of messenger molecules, what happens is hyperexcitability. So the brain is more easily excitable. And we think this is the reason that these patients suffer from migraine auras. We came to these conclusions by doing animal model work and cell culture work. So together, these led to us understanding more about the pathophysiology of hemiplegic migraine. But there's still a lot of work that needs to be done. Next, I would like to move on to the migraine in a dish, so also known as organ on a chip. So what we have cells in our body, and we can actually reprogram these cells by a very difficult lab work to become other cells. And if you have these cells, you can put them together on a chip. And when you do that, you can try to make miniature organs. So you can put the different cell types together and try to make an organ by using the right chips. And these chips are very small. But a chip like this is not enough. The lab has to be bigger than just a chip because you actually have to do a lot of measurements with these chips, which you can see on the right of this slide. So I just want to give you a bit of a feeling about what this looks like. So these are the chips you can use. And here you can see some of the recordings. So you can, for instance, measure electroactivity, but what you can also do is we can actually look at cortical spreading depolarization. And this is what we already previously mentioned, that's the wave that goes across the cortex. And now we can actually mimic this in a dish. So when you look here, you can see the wave moving. So this is in a dish, but you can actually see the cortical spreading depolarization happening. Why is this so cool and interesting? Because potentially we can test treatment like this. So if you have a kind of study experiment, you can see something, you can try to influence it, for instance, with treatment. So this is a promising avenue of research, but it still needs a lot of work. Well, finally, I want to give you one example of what the kind of studies you can do in humans. Again, there's much more work, but we don't have all day. So we have, for instance, an imaging trial in which you use a very special kind of MRI, which has very high magnetic fields, and you can use these kind of trials to actually measure metabolites in the brain, which was done in this specific study. And what they found was that the ratio between different metabolites was different in hemiplegic migraine compared to healthy controls. Is this interesting? Well, definitely, because it implies that there's a neural dysfunction in the cerebellum. And this is important to understand the pathophysiology of hemiplegic migraine, but it might also provide a biomarker in the future. So these kind of trials can help us understand hemiplegic migraine. So this is what I want to talk with you about in the research setting. Now I would like to move on to the clinic. Before I start, I just want to mention that this talk will mainly be about adults with hemiplegic migraine. Some of it is also applicable to children, but not all of it. Another talk will be later, which will discuss the pediatrics of hemiplegic migraine. So what both have in common is that often a presentation ends up in the emergency room. And this is not strange because these patients present with reduced strength of a limb. So we're all afraid that it might be stroke, and often they get a bit sleepy and they can't really talk because of the hour. So this leads to them not being able to say that they're having a hemiplegic migraine attack. And this means that they will come to the emergency room and the doctors won't know what to do. So this is a situation in which all the alarms go off because there's a reduced strength, weakness. However, even if the doctor realizes that it is hemiplegic migraine, this is still challenging because genetic testing, which is something you would do, takes actually months. So that will not help you at the emergency room to determine whether a patient has hemiplegic migraine. And we still have a patient with reduced strength. So we have to do something to make sure that it's not something that actually needs to be treated right away. So what we do, we can do several examinations to support the diagnosis if this is unclear, or to exclude other diagnoses. So for instance, you can do an MRI brain to see what's happening. You can do a lumbar puncture to look if there's an infection. And you can make a movie of the brain that focuses on the electrical activity to see, for instance, there are signs of epileptic activity. Importantly, all these different tests can help you give clues that it is hemiplegic migraine, but they more importantly can help you exclude other causes. So this is why they're also done. If someone has had hemiplegic migraine attacks before and there were no complications, they do not need to necessarily come to the ER. So this is something that you have to discuss with your physicians, whether or not it is necessary for you to present to an emergency room. Because if it's a common hemiplegic migraine, often this is not the case and patients can stay at home. However, it is important that you try to indicate to the people that care for you that you are having a hemiplegic migraine, because they will think that it's stroke or something else. So this is something that you should have a plan for. So this is a bit about the diagnostic process, but what about when to look for a mutation? Well, actually what we know that there are several factors that increase the chance of finding a pathogenic mutation in hemiplegic migraine. And this is not for all the genes, not just CACNA1A. So we know that if there's a brain swelling on MRI or CT, that the chance of finding a mutation is higher. This is also the case if there are cells in cerebral spinal fluid, if there's more than one brainstem aura feature, or if patients suffer from severe weakness. All of this increases the chance that you'll find a mutation. There are also other features that make this chance more likely. So for instance, if patients are very young when they first present, if they have several family members, if they suffer from progressive chronic ataxia, or if they have mental retardation, this all increases the chance of finding a mutation. If the attacks are triggered by mild head trauma, this also increases the chance. So together these features can help physicians determine whether to do genetic testing. This is about the diagnostic process. Next, I would like to move on to the treatment. So there are several treatments that you can give for hemiplegic migraine. And migraine treatment is often divided in two parts. We have the acute treatment and we have preventive treatment. Acute treatment is aimed at aborting a migraine attack. So the attack has to be stopped. So this is something that you only take when the attack is happening. Preventive treatment is actually given every day to help reduce the frequency, the duration, but also the severity of the attacks. So this is something that patients use daily to prevent their attacks from happening. So whether or not this is given completely depends on the patient. So if the migraine is not very frequent, it can be decided not to use preventive treatment. First, I want to give you an idea what we give for preventive treatments. And to be completely honest with you, there are not trials aimed at hemiplegic migraine themselves, these patients, because it's so rare. So what we give treatments that we know work for migraine with aura, and this actually works quite well. These prophylactics that we give are just some of them that are given around the world. Other prophylaxis for common migraine can also be tried. And what's important to realize is it's a kind of a trial and error system. So we give something, we see if it works, and if it doesn't, we try something else. It's not that easy because we do look at the patient characteristics and the characteristics of the drug to see what we think would be the best fit. But basically what it comes down to, if something doesn't work, we try something else until we find something that works well enough. So this is what we do for preventive treatment. Next, there's the acute treatment. And what's really important to realize is what we do in our adults is we try to treat the migraine headache, because currently we don't have something that is very effective, for the migraine with aura symptoms. And this is important in hemiplegic migraine because while common migraine patients often complain mainly about their headache, in hemiplegic migraine, it's actually the aura that is the problem. So this is different. So the treatment that I will be discussing now is aimed at the migraine headache and not the aura. So the first line treatments for the migraine headache are the NSAIDs. And the NSAIDs can be given together with antimimetic treatment to stop vomiting and nausea. And these are the kinds of treatments that we use to begin with. And we try to treat consecutive attacks. And if this is not successful, we move on. And here it becomes a bit controversial because this depends on in which country you live and which physician you are seeing. What we do in the Netherlands is we treat our patients with triptans. Triptans are specifically designed to treat migraine. However, when they were first done in the large clinical trials, hemiplegic migraine patients were excluded. Moreover, triptans can cause vasoconstriction. And before we understood what hemiplegic migraine was, there was thought that it was a bit like stroke, so that the vascular was very involved. And because of this, people were afraid to give triptans to hemiplegic migraine patients. However, nowadays we know that it's actually a neural disorder, so it's not the vasoconstriction that is causing the problems. So we feel very confident in giving triptans to our patients. We have been doing so for years, and we have not seen any severe side effects. So this is something to discuss with your neurologist. Again, we try to treat 3 different attacks, and if this is not successful, we switch to a different triptan. Luckily, there are many triptans, so we can switch around to see what works. And almost always we find one that is satisfactory for the patient. Again, it treats the migraine headache, not the migraine aura. So this is what I want to talk with you about treatment. And now I would like to discuss with you what I would like you to take home from this presentation. So using different types of models, we can understand how hemiplegic migraine works. We can use these models to search for a better treatment. And it's important to realize that not all patients with hemiplegic migraine have mutations in the known genes. Just as important, not all patients with COCNA1A mutations have hemiplegic migraine. It's important to realize this depends on the mutation. And depending on the patient, different kind of treatments are indicated. So I would like to thank you all for your attention, and I would like to especially thank all the patients that made these types of research possible.
Hello, everyone. I would like to start, first of all, by thanking very much the CACNA1A Foundation for giving me the honor of serving on their advisory committee. It's both an honor and a privilege to be able to help with the goals and delivering the goals of the foundation. I really look forward to the work that we're going to be undertaking. And of course, I'm delighted to have the opportunity to be able to talk to you today a little bit about the work that I do in Oxford, both at the university and the hospital. And the topic that I've chosen for today is really about how research into this gene, the calcium channel 1A subunit, CACNA1A, has taught us a huge amount, not just about hemiplegic migraine, but about migraine in general. And really, that's a large part of the work that I do. So I'll start by giving my disclosures. I'm a founder and director of Oxford STEMtech Limited and Human-Centric Drug Discovery, 2 startups that have been operating for about a year or so. And I've also received honorarian consultancy from these drug companies. So I'm a consultant neurologist at the John Radcliffe Hospital, and a large part of my workload is seeing patients with headache disorders, adult patients by and large. And very often patients will come to me with various forms of headaches. And for someone, for any of you that don't really suffer with a headache, it's very easy to dismiss. After all, we all suffer with a headache from time to time. But the patients that I see are patients that suffer with recurrent headaches that really blight their lives. And headaches are a very disabling condition that take up a huge amount of resource for health services. And it's estimated in the UK that 1 in 10 consultations are about headaches. And that then translates into about a third or so of patients that are seen in specialist neurology clinics. Headaches also present really very commonly to neurology, to accident emergency. And headache is more than just a headache. It is ranked as one of the leading causes of disability worldwide. And that's because a headache impacts all aspects of life. From your ability to concentrate, to be productive at work. And for some people, headaches can mean that they have to go to bed, that they can't function, they can't socialize. And you can see, therefore, where all the disability comes from. And so this in turn has huge impacts on the economy. It affects children, and that can lead to missing school. And of course, it affects people in the productive years of their life, and so they can miss work. And that then consequently has both direct effects on the economy through health needs, and then also indirect effects on the economy through loss of productivity. And a large part of the headaches that cause these types of problems are migraine headaches. And migraine is a really interesting condition which comes in all sorts of different forms and spectra. So we call migraine a primary headache disorder, and that's because very often there isn't a clear cause for the headache. For example, if you do a brain scan, the brain will look normal in a brain scan. But the migraine headache itself has got some very characteristic features. So the pain is often described as throbbing or pulsating. It's often quite severe, and it's associated with features such as nausea, photophobia, and phonophobia. And in about a third of patients with migraine, and I'm sure many of you in the audience will also suffer migraine as well, about 1 in 3 patients also will experience an aura. And these are transient neurological symptoms that occur usually before or around the start of the headache itself. And the commonest type of aura is a visual aura. And this can present as flashing lights or zigzag lines, or even more complicated visual phenomena. And of course, being part of the CACNA 1A Foundation and being part of this presentation, you'll also be well aware that the aura of migraine can also be a motor aura, where patients can experience weakness and paralysis. And this is hemiplegic migraine. A characteristic feature of the aura is that very often aura is short-lived and is fully reversible. And certainly, as you'll hear about from my colleagues, hemiplegic migraine can have exactly those features, relatively short-lived and reversible. But patients with genetic mutations that cause their hemiplegic migraine, their auras can be much more prolonged, and they can be extremely severe. The more that you study migraine headache and migraine itself, the more you realize that actually there's a whole plethora of symptoms that are associated with migraine. So that it is more than just the headache. And for many patients with migraine, there is a prodromal phase where patients may experience things like craving, tiredness, yawning, fluid retention. And that can occur several hours before the actual headache or the aura itself. Those prodromal symptoms then follow on to the aura, as mentioned, short-lived transient neurological symptoms, and then the headache phase, which can last for 4 hours to 2 or 3 days. That's then followed by a postdrome, after which the patient can return to something like normality. And many migraine patients go through this cycle of prodrome, aura, headache, postdrome, normality recurrently over several days. And this is why for some patients, migraine can really start to dominate their lives when this pattern starts to repeat very, very frequently. One of the things that I'm particularly interested in is trying to understand where the headache pain comes from, because unlike many other pain disorders, actually it's not clear at all what is driving the pain. So you'll know with other painful conditions that very often there's some kind of stimulus that causes that pain. For example, as in the cartoon there, you hit your finger with a hammer and that then causes pain signals to tell you that that finger is hurting to try to get away from whatever caused the harm in the first place. Now with headache, it's not clear that there is any injury like that that is activating those pain nerves. But I think what is true is that pain nerves are activated during a headache. And the particular set of pain nerves that are activated are those that arise from a structure called the trigeminal ganglion. And that structure sits near the base of the brain, and it sends out pain nerves that innervate all of the facial structures, as well as the lining of the brain, the dura and the meninges, and also, importantly, the blood vessels of the brain. And so one of the reasons that people have thought for a while that migraine has this kind of throbbing nature to it is because of the concept that perhaps the pain was being driven by dilatation and pulsation of the blood vessels that was then stimulating the pain nerves that were nearby. Now, that's probably not true, as we'll talk about in a moment, but it's a very attractive concept, given the kind of features that people describe with their migraine headaches. So if we're trying to think about where migraine might start and where it comes from, then some of the studies that have really started to shed light on that have been some advanced brain imaging studies. And there was some really pioneering work conducted by colleagues in Germany, where they took patients with migraine and put them into a scanner every day for a period of about a month, whether or not they had a migraine. And what that allowed them to do was to look at the parts of the brain that was being activated through the different stages of the migraine cycle. And so what they were able to look at and associate were then, exactly as I described to you beforehand, what happens in the time period before a headache starts, the pre-ictal phase, what happens in the brain during the ictal phase, when they're actually experiencing the headache, and what happens in the brain after the headache is resolved. And so if you can look at the networks in the brain that are activated really early on, then perhaps that might give you a clue as to what kind of is triggering the headache off in the first place. And what's been really interesting is that a key region that seems to be activated very early on is a part of the brain called the hypothalamus. And again, that's a structure that sits deep in the brain, and it's a structure that regulates a lot of our body homeostatic mechanisms. So it's the kind of thing that might regulate your thirst, your hunger, your sleep-wake, your body clock, and so on. And so there's a growing sort of appreciation that this particular structure might be a key driver of migraine headache. Now, let me turn to a phenomena called cortical spreading depression. And this is where it gets really interesting and links very closely with what might be driving the migraine aura. And of course, that's then really important for a condition like CACNA1A. So, as I've described to you before, an aura are transient neurological symptoms that occur typically before a migraine starts or at the start of the migraine headache itself. And very often it's a visual aura, although as we've described in hemiplegic migraine, that might actually be a motor aura. And a very frequently described aspect of the aura is that the symptoms will spread very slowly over the course of several minutes. So if you have a visual aura, and for example, perhaps you might have zigzag lines or a blind spot, someone who's experiencing the aura will describe that that blind spot might move in their visual field over the course of several minutes, or it might expand. And so there's a suggestion that whatever's sort of underneath that aura must also be spreading in that way as well. And so when back in the 1940s, there was a physiological phenomena that was discovered called cortical spreading depression. And this was work that arose from experiments that were performed on the brains of rabbits. And I think the original experiment, they sort of applied potassium salts onto the brain, and they observed this wave of initial activity followed by sustained inactivity of the brain and of nerves in the brain. What was really interesting was that the rate at which that wave spread across the brain in the rabbit looked to be at a very similar speed to the rate at which the symptoms of aura spreads in patients with migraine. I guess perhaps one of the most convincing reasons to believe that this kind of spreading wave of activity, cortical spreading depression, might actually occur in human subjects is that they took a patient with migraine visual aura and put them in a scanner when they were experiencing one of these visual auras. And using the brain scanner, what they were able to see was that there was a kind of matching wave of activity that was occurring in the brain of that patient, affecting the part of the brain that was controlling their vision that matched the patient's symptoms. So these days, it's pretty well accepted that the basis of a migraine aura is this phenomena of cortical spreading depression. And for a condition like hemiplegic migraine, the idea is that there is a similar spreading wave that occurs and affects the part of the brain that controls movement. And that's a part of the brain called the motor cortex. Right, so now let's turn to the genetics. This is an area where I think the discoveries around hemiplegic migraine have really transformed and reshaped what we think about hemiplegic migraine. And migraine genetic disorders present as a spectrum. There are conditions so most migraine is very common, and we think that in those individuals that there are very small genetic changes that then lead to the predisposition to migraine. But on the other end of the spectrum are conditions like hemiplegic migraine, where a mutation in one gene, like CACNA1A, is sufficient to drive all of the migraine features. And so what then happens is that the migraine gene can get passed on from one generation to the next generation to the next generation, and that's why it often presents as familial hemiplegic migraine. So why do I say that the discovery of hemiplegic migraine and CACNA1A in particular has led to a revolution in the way that we think about migraine? Well, for a very long time, probably from about the 1950s, the concept of migraine, common migraine, was that it was a vascular disorder. And that really all of the symptoms of migraine, whether it be the aura or whether it be the headache, was all to do with blood vessels constricting or dilating. But when it was discovered that hemiplegic migraine was caused by a mutation in the CACNA1A gene, then that was really all turned on its head. And that's because CACNA1A is a gene that is expressed in nerves. And mutations in that gene lead to abnormal function of those nerves, and specifically the synapses, the connections between one nerve and the other nerve. And so with that discovery, people have really started to think of migraine not as a vascular disorder, but as a neuronal disorder. And that has now, I think, very much dominated the way in which people conduct research for the last 10 years or so. And that's all really thanks to the discovery around CACNA1A, which was really led by the research group in Leiden by the likes of Michel Ferrari and Arne van der Marburg. So hemiplegic migraine is caused by not just mutations in CACNA1A, but also mutations in other genes, like this a gene called the sodium potassium ATPase, and also a gene encoding a sodium channel. And again, the commonality between all of these genes are that they are expressed in brain tissue, and in neurons. And very likely what they're doing is that they're regulating the activity of nerve synapses. So again, very much arguing that migraine is not a vascular disorder. It is a neuronal and synaptic disorder. Right. So I'm now going to whiz through some of the research that we conduct in my lab, and how I'm hoping that the work that we do might shed light on disorders such as migraine, and then also some of the rarer conditions like hemiplegic migraine. So what I'm very much interested in is trying to move away from the traditional use of animal models. We very often use mice to investigate disease processes and try and find drugs that then work, and trying instead to move into human systems, and in particular trying to get at human nerves and migraine patients' nerves. But of course, trying to get at patients' nerves is not easy. But there was a discovery that was made that really made a lot of things possible now that perhaps could not possibly have been imagined 10 or so years ago. And it comes from the concept that we all sort of arise, and all of the cells in our body come from a type of cell called an embryonic stem cell. And an embryonic stem cell has two key properties. One is that it can sort of divide repeatedly for as long as it wants to. And the second is that it can generate all the different cell types that a human body has. And the key discovery was that it's possible to reverse the process. So in other words, you can take, say, for example, a blood sample or a skin cell from a person, and then turn that clock back and turn that adult cell back into a stem cell. And that's a process called reprogramming. So why would we want to have stem cells? Well, as I mentioned, it's got two key properties. One is that it can make copies of itself as much as it likes. And the second is that it can become any cell type in the body, including pain nerves. So once we've got those stem cells generated from a patient, we can then turn those stem cells into pain nerves. And so that then allows us to start thinking about producing what I've called a headache in a dish. And the idea here is that we might be able to obtain stem cells from patients with headache disorders, with migraine, and then turn those stem cells into the headache patient's pain nerves. And by looking at the headache patient's pain nerves, we can look and see if it has any particular abnormalities. Is there anything in those pain nerves that means that that patient is more likely to suffer with migraine? And so we've done that, and we've done that with a different gene, in fact, called TRESC, which is associated with migraine. And we looked to see how the pain nerves from patients with that mutation compare to people who didn't have that mutation. And that allowed us to understand how and why this particular gene can lead to an increased risk of migraine. And what can we do with this headache in a dish model? Well, one of the things that we can do is to try to find drugs that might be able to reverse some of the abnormalities that we're seeing in a dish. So, for example, one of the abnormalities that we've observed is that the pain nerves that we are growing seem to fire much more frequently. They're hyperexcitable. And so if we find drugs that are able to settle those nerves down, perhaps that might then present as a new therapy to treat headache disorders in the future. And so we've undertaken those types of experiments to find drugs that reverse and settle down hyperexcitability of pain nerves. And we can then look at other kinds of abnormalities, not just hyperexcitability of pain nerves. We can also look, for example, to see whether the synapse that I talked about that's really important in hemiplegic migraine, is that abnormal? And if it's abnormal, again, can we find drugs that can reverse that abnormality? Some of you may know that in migraine, a really exciting therapy that's arisen are treatments that target the CGRP pathway. And again, we can look in our headache in a dish models and see whether there are abnormalities in that CGRP pathway and find other drugs that might also to be able to target that molecule CGRP. And so this way we build up multiple different ideas of headaches in a dish. I'll skip over that. What kind of resources do we have then to study conditions like CACNA1A? Well, about 3 or 4 years ago, I was leading another project called StemBank. And in StemBank, what we were trying to do was to generate stem cells from large numbers of patients in order to be able to undertake the kind of processes that I've just described. Make their stem cells, from their stem cells, make things that might be important for that individual's disease, like pain nerves or like inflammatory cells, and then look and see whether those cells, when we're looking in the dish, do they have abnormalities that are associated with the disease, and then find drugs that might reverse that. So what's really important for you is that in StemBank, we actually recruited patients with CACNA1A mutations with hemiplegic migraine. And so these stem cells are now available through StemBank to researchers around the world to be able to undertake stem cell studies to try to develop better drugs. And these type of approaches are changing the way in which we're going to discover drugs and the way in which we're going to practice medicine. So you'll know at the moment that when we do drug discovery and when we try and treat, what you have is a pill for a particular disease, and you take that pill and you assume it's going to work for everybody. But we know that that's not the case. We know that some people will respond to a medication and other people won't. And so the concept of stratified medicine was born, that within a group of individuals with a disease, there'll be different subgroups, some of which will respond to one therapy and others will respond to a different therapy. And that has moved on to another concept called precision medicine, where we're now moving away from subgroups of individuals, and instead what we're focusing on instead are individual patients themselves. So in other words, maybe one particular person will respond to one particular treatment. And of course, for conditions like CACNA1A, where there may be very specific mutations that are unique to a particular family, to an individual, it's very likely that that particular mutation will need a very specific type of treatment. And so I think for treating CACNA1A, we really need to be thinking about precision medicine. I will move on from that slide and I will finish my talk there. And thank you very much. And I will pass on to my next speaker. Thank you.
Thank you, Dr. Cotter. Now we're going to have Dr. Ingo Helbig's presentation. And we've changed a few things up so that we're going to try to control the slides to minimize the technical issues. So hopefully that works. Dr. Helbig.
Thank you so much. And again, I'm very sorry that I couldn't be there in person. I'm really looking forward to kind of sharing with you what we know about hemiplegic migraine. Sunita, I can't see my own slides right now. Can you maybe just kind of unshare? Thank you. Perfect. Next slide, please. So my team is the neurogenetics or epilepsy neurogenetics team at Children's Hospital of Philadelphia. And we're in a program called ENGINE, which is the Epilepsy Neurogenetics Initiative. And Alexis, Lena, and Olivia from our team are actually at the conference. So feel free to kind of engage them in your discussion and talk to them. And we are a clinical and research program that is mainly interested in genetic brain disorders and including CACNA1A. Next slide, please. So what I would like to talk about are three things. I'd like to kind of draw a bit of a difference to the previous talks to understand, to give you an idea of what hemiplegic migraine looks like in pediatrics. I want to talk about who is at risk for hemiplegic migraine. And finally, what are these specific treatment and prevention protocols we have in pediatrics? Irene has already given this kind of very great overview of how this is done in the adult setting, but we have some kind of modifications of this in pediatric care. Next slide, please. And next slide. So when we talk about pediatric hemiplegic migraine and CACNA1A, we think of this as a genetic neurodevelopmental disorders. And what you can see is a timeline on of all the epilepsy genes that have been discovered over the last 2 decades. And you can see in this blue kind of line, there's an increasing number of genes that are being discovered. And CACNA1A was actually not one of them. So the discovery of CACNA1A precedes the current major gene discoveries in epilepsies. And this is because CACNA1A is really more complex. We have hemiplegic migraine, we have episodic ataxia, spinocerebellar ataxia, and this is why CACNA1A has always been some sort of a special case. Yeah. Next slide, please. To kind of give you an introduction into pediatric hemiplegic migraine, I'd like to give you a case story. And I would need my slides back quickly. I cannot see my slides anymore. Thank you. So this is the story of a 6-year-old girl who had mild developmental delay and an otherwise well-treated focal epilepsy. And what happened to this girl is that she had an asthma attack and she had a very sudden decompensation. When you're in the moment of kind of admitting a child with these issues, there are lots of things going on. We're concerned about basically supporting breathing. We're trying to understand, is there anything kind of going on with respect to infection? And there's often quite a chaos or quite some kind of many things going on when children with hemiplegic migraine are first admitted. This is never straightforward. People think about a stroke, people think about a brain infection, and this is never really a very clear story, and there's lots of communication back and forth that often traumatizes families. In our case here, our girl had one prior episode where she had unexplained lethargy that kind of self-resolved after 24 hours, which made sense in retrospect. And the clinical presentation was so severe that this girl needed to be admitted to the intensive care unit. And upon imaging, we saw swelling on the right side of the brain. And the concern was kind of issued, is this an encephalitis, a brain infection, or is this due to hypoxia, so lack of oxygen that led to brain damage? Next slide, please. So what happened then was that there was a very thorough workup, which is typically done when children with hemiplegic migraine present in the intensive care unit. There was no infection found. The girl was actually found to have seizures during this episode that initially weren't really that severe and then kind of increased over the next 24 hours. And then over the next 5 days, many different therapies were done: steroid therapies, anti-seizure medications, antibiotics, antivirals, and our patient improved and eventually kind of regained consciousness and had a left-sided weakness. Yeah? So a right-sided brain swelling, left-sided weakness. From the ICU, our patient was kind of transferred to the neurology floor and then eventually to rehabilitation. She regained full strength, and on a follow-up MRI in outpatient, we saw some mild-sided right-sided atrophy, which is reduction of the brain volume. Next slide. So what you can see is actually a story that is actually very, very different from what you've heard previously. Yeah. Yet it is still a hemiplegic migraine. And this is what you can see on this slide. There is really kind of a spectrum between hemiplegic migraine that results in minor symptoms. What you can see on this brain scan here is the effect, this kind of swelling, this atrophy after the swelling in a child who had this very severe hemiplegic migraine. Next slide. So, and the way that we typically think about this is that when we see children in the intensive care unit who have a first hemiplegic migraine attack, the term hemiplegic migraine just feels completely wrong. There's no migraine involved. There's no headache involved. There's no sensory aura involved. We just have a acute critical care situation. Yet this is related to what you've heard previously. This is a hemiplegic migraine event where we're dealing with kind of spreading depression, and it's the same mechanism, just way more extreme. Next slide. So again, here's the kind of spectrum of hemiplegic migraines, the kind of common hemiplegic migraine, which is the most common form, and then the severe hemiplegic migraine, which is severe, but this is what we see in children with kind of CACNA 1A. Next slide. So CACNA 1A is not just hemiplegic migraine. CACNA 1A is really a complex neurodevelopmental disorder where we have at least 4 domains that are relevant. We have development delay and autism, we have ataxia, epilepsy, and then hemiplegic migraine as a 4th component. Next slide. And next slide. And between all these 4 components, hemiplegic migraine is really the most poorly understood feature and is the most mysterious. We understand ataxia, we understand epilepsy, we understand developmental delay, but hemiplegic migraine is really the big mystery because we have not really a good handle on how these kind of conditions progress over time. Next slide. So when we think about what is severe hemiplegic migraine, so those are neurological events in our CACNA 1A children. Those are sudden neurological decompensations. They can be provoked by fever. They can be unprovoked. They often result in obtundation, so lack of awareness, sometimes coma. They're often associated with hemiplegia, so one-sided weakness, but not always. They may result in refractory seizures, but there's children who don't have seizures, and they may result in brain swelling. When we think about CACNA 1A related hemiplegic migraine in children versus common hemiplegic migraine, these features are shared, but the clinical course in children is typically very, very different. And sometimes we have to be aware that calling this hemiplegic migraine and kind of thinking about this as a headache is actually a dangerous misnomer because this makes these episodes appear much less severe than they actually are. Next slide. So who is actually at risk for hemiplegic migraine? Next slide, please. So this is just an overview of the CACNA 1A protein that we kind of had on our blog Beyond the Ion channel a few years ago. And it just shows you the image that you already have seen and will see quite a few times during this meeting, which is the CACNA 1A protein just kind of stretched out. Next slide. So when we think about understanding risk and counseling families about risk for hemiplegic migraine, there are 2 things that are important. So first of all, we need to know what the variant is. Yeah, and we typically kind of go by the slogan or by the motto, know your G dot, C dot, P dot. So I will really motivate every family to have your genetic test report at hand, have this somewhere, and familiarize yourself with what your variant is. What is your C dot? What is your P dot? This is particularly relevant as genetic testing reports are often PDF attachments in medical records. So they do not transfer between medical centers, but it's good to have a copy of this yourself. I would like to think about 3 scenarios. I'd like to talk about the known hemiplegic migraine CACNA 1A variants, the risk and loss of function variants, and how we approach variants where we have no idea whether it is a gain of function or loss of function variant. Next slide, please. So the first scenario is a situation where we know that a variant has been associated with hemiplegic migraine. Those are variants that have either been found repeatedly in children with hemiplegic migraine, or we know that there are functional studies that have been seen, and these functional studies for hemiplegic migraine CACNA 1A variants typically show a gain of function effect. And some of these variants that you've already heard is the S218L, the R1349Q, the V1396M. And what these kind of letters and numbers mean are specific variants in the CACNA 1A protein that you will find on your genetic testing report. Next slide. So the other scenario is loss of function variants. So those are variants that are either stop mutations, splice site mutation, frame shift, or deletion. And I think Lena gave a kind of very thorough overview over this earlier. And those are missense variant, where researchers have found that this variant reduces the function of CACNA 1A. Yeah? There's some debate about this recently, but we typically think that the risk for hemiplegic migraine in loss of function variants is low or is even non-existent. Yeah? important is that sometimes the information that this is derived from may not be very precise. Sometimes when we look back at the literature that does not come out of the genetics or neurology field, people sometimes use CACNA1A and hemiplegic migraine interchangeably. So we don't even know if these individuals had hemiplegic migraines. And if in doubt, we typically give families a so-called hemiplegic migraine action plan. Next slide. The last scenario is if we have a change in CACNA1A, then we don't actually know what it does. This could be a change that is, this is often a change which is a missense change. So it's a spelling mistake in CACNA1A, which is new. Yeah? And these variants could theoretically be gain of function variants that would put a child at risk for hemiplegic migraine, or loss of function variants where the risk is very, very low. Clinical clues for gain of function effect would be early onset epilepsy. This is typically linked with gain of function effect, and this would put a child at risk for hemiplegic migraine. And as you will see during this meeting, there's some very good variant prediction tools that Dennis's team is working on that will help us kind of classify variants and get a little bit closer to what this variant might do, even if we don't have functional data. Loss of function variant can be suspected if a child has generalized epilepsy, typically absence epilepsy. And there's a typical neurodevelopmental phenotype in loss of function patients, which is typically mild to moderate delay with ataxia and nystagmus. This is usually different in children who have gain of function. Next slide, please. Yeah, and then unknown variants. We see this very, very commonly. And then the question is, how do we handle uncertainty? Yeah. What I would like to point out is that this is common, and this is what we have traditionally done. So functional effects, there are only very few variants where we know this, and the variant uncertainty does not mean clinical uncertainty. Yeah? If there's doubt, ask your provider for a hemiplegic migraine action plan. Yeah? And typically, unless really hemiplegic migraine has occurred, we would not start preventative medication. One thing that is important is that we need to be aware of other CACNA1A features. So there can be decompensated ataxia, there can be seizures, and not all these features that could happen to a child would necessarily be hemiplegic migraine. Next slide. So think about hemiplegic migraine as this kind of part of the overall spectrum. Next slide, please. And again, just the idea that this is a kind of very large and complex neurodevelopmental disorder. Next slide, please. So let me now go over to the last part where we think about treatment and prevention of pediatric hemiplegic migraine. And what we typically do in pediatrics and child neurology is that we combine concepts from epilepsy care with concepts from migraine care. Next slide, please. So again, here, who's at risk? We mainly think that kind of children with gain of function variants are at risk to hemiplegic migraine. Next slide. And next slide, please. And when we think about treatment, it is actually very important that we kind of really understand whether the term hemiplegic migraine is kind of used correctly. Yeah? So just as a side note, there are other conditions called alternating hemiplegia. Yeah? Hemiplegic migraine does not always show hemiplegia on one side. Yeah? And again, the way that this is named, the way it is right now, is historical, as CACNA1A was discovered initially through milder hemiplegic migraine families. Next slide, please. So again, hemiplegic migraine is kind of the mysterious feature of CACNA1A. Next slide. Next slide, please. Yeah, stop there, please. Yeah. Actually, go one step further. Sorry, I just gotta end one step further. Yeah. So one further, please. Yeah. Sorry, it's kind of now back to where I want to be. So when we think about hemiplegic migraine treatment, there are mainly two components. There's the baseline treatment, what we kind of treat with every day, and there's the acute treatment. So baseline treatment is daily medications. And typically when we see children who have had one hemiplegic migraine attack, Ideally, we would like to have a dual treatment, either a Diamox or a Verapamil, and then at least one anti-seizure medication. There's actually currently very little data on how effective this preventative treatment is for pediatric hemiplegic migraine. And there are many, many anecdotes. CACNA1A is a very complex disease where features are often very surprising and very complex. So anecdotes can actually be misleading. Yeah? The additional feature is the acute treatment. Yeah? And what is really important for hemiplegic migraine, if we are certain that a child is at risk for hemiplegic migraine, to immediately recognize this. So hemiplegic migraine attacks, when you think about the spreading depression that you've heard about in the last talks, is basically a bushfire. And you want to put this out as soon as possible. Yeah? And in many cases, this is really the most important aspect of hemiplegic migraine care. So we typically think that prevention and baseline treatment is the most important part. But in practice, we know that recognizing this early and starting urgent treatment early is at least as important. Yeah? Acute treatment is often underestimated, so it's really important to have a plan and to have a strategy. You know? And when we think about what people have done in the past, there are, again, many case reports, many anecdotes on how pediatric hemiplegic migraine have responded or have not responded, but they sometimes show us the exceptions and not so much the rules. Next slide. And skip one slide, please. Yeah, perfect. So here is basically what I call the CACNA1A treatment matrix, or the hemiplegic migraine treatment matrix. So we have ideas that we kind of use strategies from migraine treatment, which is Diamox and Verapamil. We think about epilepsy treatment. You know, there's always the debate, if a child has had a hemiplegic migraine attack and there were no seizures, would we start an anti-seizure medication or not? I typically would suggest this, but this is often a discussion with the family. This is prevention. And then the acute episodes is really three parts. What do we do at home? What do we do in the emergency room? And what do we do in the hospital? Next slide. So we typically think about these three components in the following way. When we think about treatment at home, I typically share with families that hemiplegic migraine episodes are bushfires, but we think about at least one medication that families can give at home, either a migraine medication, so the Verapamil or Diamox, or a seizure medication if we have a history of seizures, to kind of get this started and to kind of treat this very urgently. In the emergency room, so we always like to get our patients to the emergency room as soon as possible. You know? It's very important to kind of let the staff know as early as possible that a patient, a child, has a CACNA1A related hemiplegic migraine. And typically our patients have an action plan that I ask them to kind of show the emergency provider to say, here, we're not dealing with a stroke. It's more likely that we're dealing with a hemiplegic migraine event, which is important because we need an EEG and we need brain imaging. Yeah? And we typically recommend some IV treatments straight away. The most effective is steroids. In the hospital, we typically recommend observation for at least 2 to 3 days. There are some stories of hemiplegic migraine events being initially treated and then not continued, and then the brain swelling gets worse. Sometimes, if there's doubt, repeat imaging is important, and we typically really kind of ask for aggressive treatment each and every time, just to keep the swelling and keep the seizures down. Next slide. Yeah, important. CACNA1A-related hemiplegic migraine is not a stroke. This is often something that is very confusing because strokes is what we typically expect, but emergency room teams are prepared for. You know? The brain swelling in CACNA1A can be more severe than in strokes, so it can be more dangerous than a typical stroke. And it is often very important to rule out other causes. A child may have CACNA1A, but there may be other kind of issues that may be at play. There is no one single recipe for this. The treatment is always individual, depending on where a patient is in the journey and in treatment. And there are reports of specific medications working differently in patients. There are some medications that may work the same across medications, and this is currently not clear. No? Again, general principles, think about treatment in 2 different pathways, migraine and epilepsy, and these 2 aspects, preventative medication and acute treatment. Next slide. And next slide, please. So how can we know more? And I want to kind of move away now from the kind of clinical part to really understanding how can we actually get some idea of what hemiplegic migraine is and how this kind of happens in children. This could be clinical trials. We know about natural history studies. And what our team does is a method that is called phenotype reconstruction. Next slide. So this is part of what our research lab does. So we have a kind of computational and bioinformatic research lab, and we kind of try to understand how can we take all this information that we collect in the CACNA1A and other rare diseases and really kind of understand how is CACNA1A different, not by going in and looking at every kind of chart manually, this is too much, but making our computers do the work. This is part of our data here, where we kind of have more than 600,000 patient encounters with more than like 5,000 patient years, a total of more than 2,000 individuals now, including roughly 30 individuals with kind of CACNA1A. Next slide, please. Yeah, and this is what these kind of phenotype reconstructions look like. So we kind of try to take this natural history and really kind of try to draw this out. So what you see on the left is basically patient data from an entire cohort. Those are 40,000 patients. On the top right, you can see the changes in seizure severity. You can see these gray lines that go up and down. This is a patient who has initially a high seizure count, then lower seizure count, and this is recreated on a month-by-month basis. Below this, you can see several medications that the patient is on. In the middle bottom, you can see this kind of landscape wavy plot. This is basically looks at a medication landscape across an entire disease. Yeah? And then we can use this to kind of understand what is comparative effectiveness. This is now a comparison about which medications work best, looking at retrospective data. So this is the RareX citizen data that we can use for this. This is our data that we can reconstruct. And this helps us use all the data that our families are giving us to really kind of make sense of this. Next slide, please. So this is what it looks like in like 3 different disorders. And CACNA1A is soon going to join this. But what you have here is SCN2A, S6BP1, and SCN8A. What you can see here are basically several months. So every bar is a single month from birth until the age of 3. And you can see different colors there. And these colors tell us the seizure severity at a certain month. So for example, at the top, you can see children with SCN8A, how this group of children changes with respect to seizure frequency. You can see it kind of increases first, then it kind of stays constant, then it decreases. S6BP1 is initially very kind of intense, then it kind of slows down a bit just to increase again when infantile spasms come on. SCN2A here kind of looks at the entire cohort, loss of function, particularly don't have seizures during this time and gain of function. And this gives us these patterns that are very specific for a unique disease group. Yeah, and CACNA1A again is in there. We currently try to understand how can we engineer hemiplegic migraine into this? How can we see the relationship between seizures and hemiplegic migraine, and then understand this in the context of medication? Next slide. And again, this is what is called phenotype reconstruction. This is the kind of the topic of my research group. It's very granular reconstruction in rare diseases. We're interested in kind of so-called virtual clinical trials. So using existing data and really trying to understand what has worked in the past using the electronic medical records. And this is particularly important because many of the medications that we're using right now, Verapamil, Diamox, it is very unlikely that there will ever be a prospective trial to kind of really test this sufficiently. And this information with all the kind of medications that we've used in our patients, this information is out there, and we're trying to understand how we can use this. Next slide. So I want to give you a small overview of hemiplegic migraine and CACNA1A in pediatrics. I shared with you that we're mainly concerned about gain of function variants versus loss of function variants that have a lower risk, that we have these kind of dedicated protocols for prevention and treatment, combining migraine and epilepsy pathways and thinking about preventative and acute care. Next slide, please. Again, I'm part of the kind of CHOP epilepsy neurogenetics team. So we're a very large team of specialized providers who basically exclusively work with neurogenetic disorders, including CACNA1A. Lena, who's at the conference, is our main counselor for CACNA1A. Alexis, who's there. Alexis, I don't know, maybe you could just kind of wave your hand quickly in case people don't know you yet. Is our epilepsy neurogenetics fellow, who has a particular interest in this and has gone to this conference now during her first week already, working on our team. And we basically have an entire support staff with PT, OT, and genetic counseling assistants. Next slide. And then I always want to give a shout out to my research team. So I run a relatively large research group at Children's Hospital of Philadelphia, where we kind of deal with trying to understand the genetics and phenotypes of rare genetic epilepsies, including CACNA1A. Thank you.
I think we're going to do questions now with Dr. Helbig and Dr. DeBoer. I don't know if Dr. Cotter is able to come back. He was having some connectivity issues just like us. So we'll direct our questions to those two panelists. Do we have some virtual questions we want to start with?
Yes. All right. We also, before we get to that, we just wanted to remind families here that there is a really nice and wonderful guide to the hemiplegic migraines that was a collaboration through the foundation and wonderful parents, as well as some of our researchers here. So please feel free to grab them, grab a bunch of them, because you can hand them out to your teachers at school. Maybe even when you go to the hospital, you can hand those out also. So don't forget to pick those up. Okay, we have a very lively discussion on the virtual board, so let me see if I can tease out what everybody's asking. So early on, somebody asked, if there is muscle weakness in only the jaw, the hands, and or thighs during a migraine, and it's usually on the side of migraine pain, is that still considered a hemiplegic migraine? If you need me to repeat it again, I can. Any insight into that?
It's always really difficult to say something just based on a question like that.
Right.
But one of the things that's really important to realize is when we talk about the migraine aura, is that very often weakness and sensory are confused. So that's something that's really important. And this is mainly because when patients feel that there's weakness, this is sometimes actually because they don't feel their hand. So they say that they have weakness in the hand, but it's actually that they don't feel what's going on. So that's always the first step, that you have to decide, is this a weakness or is this a sensory problem? And sometimes we actually ask parents or patients to actually videotape it, because it can be really difficult just based on what the patient says, because sensory and weakness is very close. So this is the first point that we always have to decide on. Secondly, which part of the body can be affected? Well, basically all the limbs and the mouth as well. So this can definitely happen, but often what you see is that there's a different distribution than what you described. So I won't say that it's not the case, but you would have to really look into it to be sure that it's weakness and it's indeed hemiplegic migraine. I hope that answers the question.
All right, thank you. Do we have any in-person questions here? Okay, there's a hand up there.
There you go. Hi, I have two questions. One is for one of you. This is Jen. Hi, Ingo. My question is, you mentioned that the most of the variants for hemiplegic migraine were gain of function, but are there loss of function also related with this particular clinical phenotype? Is that a certain thing, or we just don't know? There is some gray area on that distinction at the molecular function versus the clinical manifestation. So that's a question for Ingo. The other question is for the cortical spreading, the organ on the chip. And my question is, what kind of model you're building? Is it cortical, or is it you specifically making the cerebella organoid, or how do you decide? Because mostly the spreading is a connectivity issue, and how do you model that? Thank you.
So I'm actually going to pass this on to Irene because it's actually this is a good discussion. I don't think that there's any kind of sense that loss of function variants cause hemiplegic migraine, or would you object?
Yeah, actually, that's completely true. It's a really interesting field that we still need to work out into more detail. And one of the important things that Ingo already mentioned is really important to know if the literature is correct, so that it is indeed hemiplegic migraine that's being discussed. Because as I mentioned previously, it's very easy to misdiagnose. And especially if there's a little patient, so a child who has very complex pathology, it's so easy to get the wrong name on the diagnosis. So that's something that you really need to be sure about.
And I must say, I mean, I wouldn't even understand how this would mechanistically work, right? Because you need a gain of function effect to produce cortical spreading depression. I would maybe even add that there's sometimes an automatism how variants or how reports are being issued. So you might get a report that says CAGNA1A loss of function, you have hemiplegic migraine. But what the lab has just done is just kind of pulled the literature, what is known about CAGNA1A, and put this into this report. And often this gets then kind of mixed into the literature, into the kind of publications there. And I think I've never seen a loss of function variant causing hemiplegic migraine. And I would maintain that this is all gain of function effects, and that in fact the literature is imprecise and that there's actually very little ambiguity.
Mechanistically, we can't explain it. So exactly what Ingo said, we wouldn't be able to explain it. And what we see often indeed, that when it gets done in a genetic testing lab, you just get hemiplegic migraine. If it's something with CAGNA1A, and it doesn't matter what. And then it gets put in a medical file because they just copy paste often. And then they come to a different doctor and they just assume, oh, it's hemiplegic migraine. So that's really important when you get your children to a physician to make sure indeed that every information that is there is the right information, because it's not always the case, unfortunately.
Yeah, and it's sometimes very hard to get information out of medical records once has been deposited. There's like copy forward, and
Impossible.
Once in there, it's hard to get this out. Yeah. So this maybe even kind of, I would maybe call on families, if your child has a loss of function variant and does not have hemiplegic migraine, really kind of ask your provider to correct this in medical records, knowing that we're using more and more of this information to actually describe this condition. Yeah, this is maybe just one feedback I would give.
And I think I can answer the second question. I think Sam would also have a very interesting answer to this question, but as he's not here, I would do my best. So currently we are still working on modeling the brain, which is already quite challenging. But of course, the brain is very complex. And you have the cortex, but you also have all the different parts of the brain that are more inside the brain. You have the cerebellum, and even the cortex itself. You have the visual cortex, but we also have the motor cortex. So it's much more complicated than we would like to believe. And this is something that we really have to take in consideration when we do these types of assays. So when you use organ on a chip, currently, we can already learn from it. We can also possibly test treatments in it, but you have to keep in mind that it's an organ on a chip. It's not a real brain. This is also why sometimes, even though we would like to not use animal models anymore, we still have to go back to the animal because they do have a whole brain. And so we can do experiments there that we can do currently in organ on chip. So while organ on chip is a very interesting mode to study these kind of disorders, we still have to take in consideration that it's not ready yet. So we still have to work on it. And what you said is completely true. The connectivity is so important. So this is really something we have to take into consideration when we do this type of assays. And we have to consider what we're testing. So are we looking at the visual cortex or are we looking at the cerebellum? So this is something that we really have to take in consideration. And that's why sometimes we have to do different assays for different questions. I hope this answers your questions.
Thank you. And I think we'll take a virtual question.
Sure. I think someone's looking for some clarification. It was directed to Dr. Helbig, but I'm sure anybody can answer that. She's asking how you would if you would classify all migraines seen in CACNA1A patients as hemiplegic migraines. Are there other qualifying symptoms or presentations that would go under that? And I know you kind of touched on how you have to define what that correct or define it correctly to begin with. So do you have any clarification about that?
So hemiplegic migraines in CACNA1A, they're often very severe events. So what we see very kind of rarely, and I would actually also kind of loop Irene in because we see the kind of different spectrum there. So we rarely see common migraines in CACNA1A because many children have basically developmental differences where this is often not as clearly expressed. So in migraines in children with developmental differences or kids who are nonverbal, they typically present differently. Yeah? Yes, patients with CACNA1A can have typical migraines, and we would usually not think of them as hemiplegic. Irene, what's your thought about that kind of typical migraines in CACNA1A and how we think of them as being related?
Yeah, I completely agree. Often what we see is that patients with CACNA1A mutation have severe hemiplegic migraine. So it's kind of difficult to miss the diagnosis. Well, sometimes in normal hemiplegic migraine, it can be quite challenging to get the correct diagnosis. But migraine is very common. The disease occurs very frequently. So just by chance, there's a chance that people will also have normal migraines. But what's also really important to realize is that we get a lot of patients with CACNA1A variants, which is unclear if it is causing the migraine. So they come with common migraine and they come with a CACNA1A variant, which they found due to genetic testing. And then they ask, is this hemiplegic migraine? And then we say, no, it's not a hemiplegic migraine because there's not weakness. And then the next question is, of course, is it then caused by the variant? And we don't think it is. We can't say it for certain, but we don't expect it to be because once there's a CACNA1A variant, you expect there to be hemiplegic migraine. Yeah. And often patients with hemiplegic migraine can also have normal migraine attacks. But then we still classify them as hemiplegic migraine because they have attacks with weakness.
And I think Zamil had a nice slide with this gradient of migraine, hemiplegic migraine, familial hemiplegic migraine. So we would expect the more severe events in CACNA1A. You know? I think practically we don't have this kind of conundrum too often. So there's often not so much the question is does a patient only have milder events and would we kind of classify them as hemiplegic migraine? In most cases, patients have at least one hemiplegic migraine event. And then the question is, Irene said it, the question is if there are other headache events, do we think of them related? And we typically would if they're related in terms of the story, but there may be other things going on that may be unrelated to CACNA1A.
All right, thank you. Do we have another in-person question? Okay.
Hi, I was wondering if you have any data or insight regarding sedatives, anesthesia, specifically propofol, being known to cause hemiplegic migraine in CACNA1A patients, and if you have any guidance for those families that have experienced those events, should they need any type of sedative in the future for themselves or their child.
Again, I think there's a discussion between Irene and me. So in terms of propofol, so I know the anecdotes. I don't know any systematic data. So I don't think that propofol is necessarily contraindicated. You know? And it's sometimes important to kind of really to say this because there's sometimes good reasons why individuals with CACNA1A should get propofol. So in my understanding, there's no correlation that this is a kind of common provoking factor. Yeah? Knowing that sometimes situations around giving propofol can be quite complex, so it's kind of hard to tease out, is it the medication, is it something else going on at the same time?
Yeah, I agree, and something that we also need to take into consideration, we have to take every anecdotal evidence seriously, but at the same time, unfortunately, in the literature, there's just a lot of pollution. Because sometimes the diagnosis wasn't right, sometimes what actually happened was misinterpreted. It can be quite challenging for physicians, which normally don't see these patients, to actually understand what's happening. So I think currently there's not enough evidence to say there's contraindication, and sometimes it's needed. So that's something to take into consideration. At the same time, if something happened during giving propofol to your child, then of course you need to take that seriously. but there's not enough evidence currently to call it for a contraindication.
And so maybe an additional thing, I think that I see this the very same way. I think the additional thing that I would say is, while CACNA1A is increasingly diagnosed only over the last 10 years, this disease has always been there. And typically, if there are very kind of characteristic side effects or very characteristic severe consequences, we would know them. So propofol has been used so often that if there was really this kind of regular pattern of a subset of children decompensating with this, these things are often known, and they often appear in a much different context. So this is not something that we'd be surprised about by finding this out now, but this would be something that would be already common knowledge.
All right, thank you. We're going to take another question from our virtual attendees. Somebody had a question about, anybody have any experience using lacosamide instead of lamotrigine for hemiplegic migraines? Any comments about that?
Well, I'm also looking at the other side of the screen for this one, but I personally do not have any experience with that. Lamotrigine is something that works really well. At my hospital, we're a big fan because there are very few side effects often. So this is what we go to, one of our first steps. But Ingo might have different views on that.
And I think, you mainly use this for like preventative headaches, right? Or is this for sometimes anti-seizure medications like lamotrigine are used for kind of different purposes. So we even give sometimes Depakote for common migraine, completely unrelated with to hemiplegic migraine. And when we think about lacosamide in epilepsy or treatment or in hemiplegic migraine prevention in the setting of hemiplegic migraine seizure overlap, it's important to know that these medications are not related to CACNA1A, so they don't work on the CACNA1A channel. And often medication response is quite unique to a patient. So there might be one patient where this works extremely well. There might be one patient where this does not work at all. There is no kind of pattern why this should work better in CACNA1A than other conditions. It is basically one of the kind of regimens that we have to treat CACNA1A related seizures and potentially use this in the prevention of hemiplegic migraine events with seizures.
Thank you. I think we have time for one or two more questions. Is there any more questions in the room? Okay.
Oh, I think we're just getting started. I have as much time as you guys want. Yeah.
Okay, so my son had a giant hemiplegic migraine experience when he hit puberty last June, and we didn't know what it was, and he went into he does not get seizures, so but he went into a like shutting down. He kind of would like shut down, like you'd be talking to him. He lost his vocal, and then he would shut down. So I was wondering if you know what that was. The neurologist described it as possibly that he was just going into shock, and his system was like shutting down. But I'm wondering if that was a seizure type situation. And my plan for the future is pretty much the same as his general migraine, number 2, is his general migraine plan, which is the verapamil and the ibuprofen, and then, just the standard, but not to rush him to the hospital. And, we'll be calm now. He knows if, again, it's going to go away. We know what it is, et cetera. But are you recommending that they go to the hospital immediately, or is that, we keep saying severe, so I'm just kind of wondering. So one, if you know what those shutting down were, and then that turned into a rage, so everybody knows, but he'd gone into a rage coming out of MRI anesthesia, and so I think that was related to just him having that. But if you knew what that was.
Irene, let me maybe try to answer this, and then I need you to kind of clean things up. Yeah. So the idea is the following. So when we think to answer this first question, it's often very hard to kind of go back and say, what are these episodes? I think the main important thing is that hemiplegic migraine events, the presentation of them is not mysterious. So when we think about hemiplegic migraine events, we think about the negative effects, like loss of function. This is basically is always connected to a certain brain area that is not working. This can be loss of speech when this is on the left side. This can be left-sided weakness when it's on the right side. So the phenomena that we see, the clinical features that we see in patients that are neurological, they are often quite clear depending on what brain region it is involved. Yeah? This is one thing. Those are the neurological features that are associated with hemiplegic migraine. And I think it would make sense to go back to your neurologist and ask, where was actually the swelling? Which side was this on? Do we have an idea? Was this left-sided, right-sided? And then often makes sense to get a better idea of what the deficits are. So the neurological term for the brain region not working, and this shows, is deficits. With regards to the other question on what your kind of plan should be going forward, I think it's often very difficult for us to really give like medical advice, not knowing all the facts. And I typically like to kind of step back a little bit and talk about more general issues. And I think generally we can say the type of CACNA1A change typically would tell us a bit. If this is kind of one of the changes that we typically see in mild hemiplegic migraines, I think we can be reassured that there's a pattern to it. If this was one of the kind of hemiplegic migraine events where brain swelling has been described, it's often very hard for us to understand what is the kind of pattern between a milder episode or a more severe episode. Because it might be that an episode may actually progress if it is treated later, and then brain swelling happens, and this can sometimes be very dangerous. So I wouldn't be, let's say, very reassured of kind of giving advice of not going to the hospital without knowing more.
Yeah, I think I would give the same advice. So if you recognize the attack, and if the attack is always sort of the same, then we give our patients the advice, all right, you don't need to come to the hospital because we know what's going to happen. We know how you have to treat it. There's not a point to coming to the hospital because we'll do the same thing that you can do at home. However, if they have a different type of attack, if they have something they do not recognize, then I do recommend that they come to the hospital because then something else is happening than normal. And then we need to reevaluate what's happening and to make sure that it's indeed the hemiplegic migraine that's going on. So that is what we give advice. That's the advice we give to our patients. To answer your other question a little bit, because I think you already get a very excellent answer. We do see patients with hemiplegic migraine that become unresponsive during the attack. And that can be due to several things. So they can kind of get a bit sleepy. They can become unresponsive indeed because there is an epileptic attack going on as well. So different things can happen. And really you have to be there to evaluate the patient at the time often. Or there has to be some kind of movie or someone had to be present that can very well describe what's happening. But it can be really difficult because often when it's the first attack, people are panicking, which is really logical because it's really scary what is going on. So these kind of attacks, we really need to know what's happening to be able to say, is it part of the hemiplegic migraine or is it something else that's going on? But we do know this in the literature and we see this in the clinic that these kind of episodes happen. So I hope that answers your question.
Irene, if that's okay, I want to add one more thing. And I think the way that you can think about neurological features in hemiplegic migraine, those are deficits. Yeah? This is, for example, agitation or excessive movement is not due to a hemiplegic migraine. This may be some secondary event, agitation because a child feels that they cannot speak anymore. But all the features we see, all the deficits we see, they are logical. Yeah? So those are not unknown conditions that only happen in CACNA1A. Those are the events that we would see if there was a stroke at the same time. And again, hemiplegic migraine is not a stroke, but the symptoms can be the same. And there's typically a system to what we see in patients and where the hemiplegic migraine attack is. And I would maybe go back, challenge your neurologist and say, explain this to me, yeah, so I understand it.
Yeah, exactly. And what we do, if we have a patient with something that we do not understand, because we said, well, this is odd for hemiplegic migraine, then we just make extra sure that it's not something that we're missing. And if we exclude all causes, we become more cautious. That's something that needs to be done.
All right. Thank you, Dr.
Can take one more question, right?
Well, we do have to move on, or?
Do you want
Sure.
one more? Just push this.
Well, actually, I think this one's actually going to be pretty long, so I may tell them to email us. That's right. I know that we have our next speaker is coming up. All right, we have our next speaker coming up. Thank you, Dr. Helbig and Dr. DeBoer, for this lively discussion.